I'd like to thank you for taking the time to attend our presentation. Welcome to Meaningful Use in 2015. Our speakers today are Kay Jackson, Cindy Paul, and Mike Elvin. Kay is a manager of software certification and compliance and application software at Iatrix Systems. Cindy is a registered nurse with over 20 years experience in clinical nursing and public health education, is a consultant in our professional service division at Iatrix Systems. She has experience in hospital compliance and quality improvement, meaningful use attestation, and audit readiness for hospitals. Cindy's primary role at Iatrix Systems is meaningful use project management and consulting and clinical informatics. As a leader of patient engagement services at Iatrix Systems, Mike Elvin works closely with hospitals, nursing facilities, and other organizations to enhance patient and staff engagement while improving health outcomes. Mike has an intensive healthcare communications background, which includes marketing deployment at Boston's Dana-Farber Cancer Institute, as well as patient engagement and internal communications at Hospital for Special Surgery in New York City. And now I'll turn it over to Kay to get us started.
Okay, thank you so much, Sandy, and hi everybody. Welcome to our presentation today. Cindy, Mike, and I hope you get a lot out of this information we're going to pass on. It's what we're seeing and hearing in the marketplace. And I do apologize for my voice. My granddaughter said I sound like an old lady, but I really told her I just have meaningful use-itis, which means I'm on an overload of meaningful use. But thanks again for coming and answering our survey pre-presentation, and we had about 50 different topics people asked us to talk about. So we're going to be here for the next 24 hours talking. Just kidding. We had a lot of questions about eligible providers, but our presentation today is about eligible hospitals, and watch for an upcoming presentation on eligible providers. So we're going to try to cover as much as we can for the topics that everyone asked for. This presentation will be provided to you, so feel free to, you'll be getting this presentation. Excuse me. Our agenda today is we're going to talk about the reality of what is really going on in 2015, the Flex IT rule and some changes that happened on that. We're going to touch a little bit on ICD-10 and how that might impact meaningful use. We're going to talk about some meaningful use coding, our favorite topic, CQM. We're going to talk about some Stage 2 concerns, and that covers Core 6, 7, 11, 12, 13, 14, 15, and 16. And we're going to talk about other ways to plan for having a success for meaningful use. At the end, I'm going to talk a little bit about what I see is going to happen with Meaningful Use 3, and also we're going to have just a very short overview of our tracking tool called Meaningful Use Manager. So I always like to give you my email address at first. A lot of people say, oh, I wish I'd had your email address to send you questions. So it was on the front slide, but I'll give it to you again. It's kay.jackson@iatrix.com. So feel free to contact me if you have any questions. But our real reality for 2015 is our time is being drugged in a lot of different ways. We've had more projects than ever from the revenue stream side, and that was my prior work. I was in revenue cycle at a hospital. Revenue is going down. Reimbursements are going down. But guess what? You still need the same staff or more to really manage these government initiatives and oversights that have been released. And the knowledge base is lower. I talk to friends that say, wow, I can't hire good people. You know, there just aren't the good people with knowing things and having resources in-house. So the reimbursements have hurt us a lot. I talked to a CIO a couple of weeks ago, and he told me he had 87 ongoing projects. He couldn't even name them all, let alone know where they stood. So we see that a lot right now. And as a result of all those projects, we see a lot of C-level management that are really concerned about their ability to have the right staff for the right project at the right time. So I really suggest when you're building your plan for 2015 and on, make sure you put into place what are going to be your resources to meet this project. And not just meet the project, but all the ongoing maintenance of a project. You know, it's kind of like meaningful use. You say, okay, we've attested, we don't have to worry about it again for another year. That is absolutely not the case. SSI Search did a survey on CIOs, and I was really surprised on the results because the results showed that meaningful use for CIOs was still the percent was 55% of CIOs said that was their #1 concern. EHR optimization was second, and analytics and initiatives was third. And by the way, we are moving into that analytics market. So what we're seeing is they're changing HIS vendors, they're updating platforms, and they just don't have the staff to handle those projects or other projects. So the Flex IT rule. So what is that? October of last year, Representative Elmers, which I really take my hat off to her, introduced that bill to Congress. What it was going to do was provide a reduction in the reporting period for 2015. I haven't talked to anyone yet that doesn't want that to pass. Well, come the first of the year, the new Congress, it was the 114th Congress, they reintroduced this bill, and now it changed to House Bill 270. So the status of the bill is on January the 12th, it was referred to the Committee on Energy and Commerce and Ways and Means, and now it has 26 other co-sponsors. So it's kind of built steam up. And you can actually track the status of any bill. GovTrack.us is a way you can go in, find the bill you want to track, and it will send you a daily email. What I was reading from writers about this bill was that they didn't think it would pass, that it takes forever to get a bill out of Congress. But where CMS came to the rescue on January the 29th, they released a statement that they finally are listening. They didn't say they were finally listening, but this is my take. They're finally listening to everyone in the marketplace that's been telling them for the last year that something needs to be changed. Last January, end of January, they actually sent a letter. There were 17 stakeholders that sent a letter to the Secretary Burrell saying, you've got to make some changes. At HIMSS, in February last year, I thought there'd be a great announcement, but there wasn't. So a year later, CMS is finally saying, okay, we've got to take a look at this. And what does that mean to you? What does it mean to all of us in healthcare? Well, this is the highlights for the hospital side. They would change the reporting period from the 365 days. So right now, you are in the 365-day reporting period. It started October the 1st of 2014. Now, CMS says they're considering this new rule. I don't know what their definition of considering is, but I'm hoping that they do more than consider and really listen to what the marketplace is telling them. What they're saying is that will give more time to secure workflow for reporting. I know we had a lot of customers that finished stage 1 on September the 30th of last year, and immediately, very next day, had to start stage 2, and they weren't totally ready. There was a lot of things that they didn't have in place. The one that I was surprised at is that they said that they're thinking about changing. The hospitals currently are fiscal year. The physicians, the EPs, are calendar year. Now they're thinking about changing the hospitals to calendar year. What will that mean? That would mean you get a whole extra quarter to actually have a quarter to a test. If that passes, you get a test October, November, December of this year. January the 1st, you would start the new reporting year. So I'm hoping that that does pass. It does give some extra time. But CMS also said they're going to make modifications. And if you guys remember, August of 2012, CMS came out with modifications for stage 1 that went into effect in 2014, and what they did was change the age on vital signs and changed Core 11 and 12 and said, okay, now you have to have a portal and provide access. So that was a change of modification. I don't know what these modifications may be, but this is their statement that there are aspects of the program they want to match more long-term goals. They want to reduce complexity, thank you, and lessen providers' reporting burden. So we'll see what that happens. Again, it's under consideration. They say the time frame is spring, so that's March, April, May. CMS likes to release things right around the holiday, so maybe Easter, maybe Memorial Day. But regardless, it's going to be a long time into your current reporting year. What we're telling customers is go ahead and move forward like it's a full 365 days. Then when it changes to a quarter, you can have a happy dance. I went ahead and put ICD-10 in because I still get questions a lot about ICD-10. How's it going to impact by meaningful use? And excuse me, just keep in mind that ICD-10 actually started in 1983. 9 years later, it was finalized. So that's kind of a few years ago. It's going to start in the U.S. October the 1st of this year. They've delayed it 2 times. I don't think it's going to be delayed anymore. And remember that ICD stands for International Classification of Disease. Most other countries have been doing ICD-10 for a long time. So this is something they're used to. We're just now getting into it. And it doesn't impact CPT coding for outpatient procedures or physician services. But there was a recent healthcare poll, again, I just read 31% of hospitals still want ICD-10 to be postponed again. So delays in payments, be planning for that. You may see that with some of your commercial payers. ICD-11 is set to be released in 2017. So Cindy, I know you talk to a lot of different customers. What are you hearing about what they're doing for testing of ICD-10?
Thank you, Kay. So, like you said, there have been lots of delays for ICD-10 in the past, and at this point, hospitals are really well on their way with implementing and testing their ICD-10. And I'm hearing lots of challenges which are affecting everyone from their executive leadership, medical staff, and especially what coders and clinical documentation specialists are facing as we really approach this October 1st deadline. And this doesn't leave out all of the additional requirements that the IT staff are having to face as far as the implementation. And just like you were speaking, it's one of those 88 requirements that IT departments are really facing and struggling to get it all rolled out by the October 1st deadline. So actually, meaningful use has really taken sort of a back burner as hospitals are now focusing on ICD-10 readiness, and it's really proving to be just as difficult as the meaningful use implementation and journey has been for some hospitals. I guess the big take for this is I really want to emphasize the importance of having your ICD-10 implementation completed and rolled out live by October 1st, because it truly does affect meaningful use as far as quality reporting, the clinical decision support rules, and those measures that really directly impact patient safety and quality of care. So I know we're going to talk about more how ICD-10 and specifically IMO really impacts the importance of having these all in place by that October 1st deadline.
Yeah, I'm glad you mentioned IMO because I'm still having sites ask me about that. So would you quickly just remind them why that's important?
Right. So IMO offers, or part of your contract and collaboration with IMO includes a quarterly update, and it's really important to make sure that you're doing these updates, because as we get closer to the ICD-10 deadline, then IMO will gradually begin pulling in those ICD-10 codes. And so this isn't anything additional that you have to pay for. It's just making sure that you're doing those quarterly updates that are included in your contract. So if you're not clear on what's needed, make sure that you contact your IMO project manager, or you can also contact me and I can help make sure that you're, getting those updates done and making sure that we get all of the required codes that are needed as we move forward in meaningful use.
Thanks, Cindy. There was another historical announcement by HHS in January. I don't know if you saw it or not, but what they stated is we are moving from fee-to-service to fee-for-value. So CQMs, kind of been put in the back burner sometimes, but they are going to be more and more and more important for you. In fact, United Healthcare just announced today that for their 11 million insureds, that they're going to be partnering with 250 ACOs this year, and that their reimbursement is going to be based on quality, just like CMS is. And CMS is saying, value is what we're looking for, quality is what we're looking for, and by 2018, 50% of the Medicare reimbursement is going to be tied to value-based. So just keep that in mind with your CQMs. And I wanted to just quickly talk a little bit about CQMs. Every year the CQMs for the physicians and the hospitals, they update. So the April 2014 update is what you're going to be looking and working with for this reporting period of 2015, and vice versa. The 2015 you'll be working with for 2016. What's about to change, though, is that CQMs, most vendors got them certified back in 2011, 2014. With this new initiative with QRDA Category 1, vendors are going to have to get their CQM certified every single year because there's going to be changes and they want every vendor on the same version. So just keep that in mind and really think about where you want to go with your CQMs. Right now, CMS says for 2015, you can still manually attest. When you go to attest with your quorum menu, you can attest with your CQMs. They said that it's going to start being required electronic October of this year. Of course, that may change if the reporting period changes to January. They're still having a lot of problems with the pilot program, so they did allude the last vendor call that they may postpone that. So if they do, we'll be sure to put it out on our Meaningful Use I-Form to let everyone know. But under the QRDA Category 1, ED3 is being dropped. So there'll only be 28 CQMs going forward. And what is QRDA Category 1? Well, CMS first started with Category 3, which meant aggregate data. So if you're testing last year, you're testing this year, it's going to be aggregate data. It's no patient-level data. What QRDA Category 1 does is it's an individual file for every single patient that falls into your CQMs. Much, much, much data. You would not believe how much data you will be reporting on a patient level to CMS on all of these CQMs. So all the CQM providers are going to, mostly like we have, we've already gotten certified for QRDA Category 1. Now we're testing it. So CMS also just came out with this eCQM Resource Center, and we've made some hyperlinks throughout this presentation to help you get to those resources. But just to let you know, some of the things, if you haven't heard this from your CQM vendor, there's a bunch of changes for 2015. I'll give you a couple of examples. Stroke, the orders are going from palliative care to comfort measures. VTE will now include additional medication groups and some new lab tests. And AMI2 is going to include new med value sets. So there's a whole list of things that are changing for this reporting period for the CQMs, and you're going to see that going forward. Cindy, you know, I know you've been working with several of my customers on CQMs. What have you been seeing from customers that they are saying about their CQMs?
Well, like you're saying, Kay, a lot of the CQMs really have specific aspects to that particular CQM. And so what I've been doing in working with sites is really helping evaluate their demographics, particular diagnoses, or really what is applicable to that hospital, and making sure that in their CQM selection that they're choosing the CQM that really fits well into their workflow, doesn't create a lot of extra work and stress on the staff, and also just making sure that it really applies to them specifically. So, where I'm really seeing folks struggle is making sure that each of those aspects of a particular CQM, like for, say, stroke, making sure that they're answering the questions appropriately for the medications and such. And so, some hospitals are choosing to do documentation concurrently where, the nurses or physicians are documenting right then and there, and that's really the best practice. The downfall to documenting on the back end is, medical record staff or the clinical documentation specialist, whomever is doing that within the site. If they're documenting after the patient is discharged, like 2 weeks later or whatever, then, there's kind of that delay in having the information available. But that is a process that some folks are doing because it's better for their particular workflows, and it helps to reduce some of that stress off of the nursing or physician staff. So one thing that I've really been doing also with our customers and other, even customers that don't have our Meaningful Use Manager tool, I've been offering some clinical consulting work where we really look at the CQMs, again, making sure that it's specific to their population and helping with the workflows, and then making sure that each of those specific questions are answered, and also, like you mentioned, making sure that the appropriate value sets are mapped to those quality measures, which is another real important aspect of the QRDA. So Kay, I guess really it comes down to each hospital evaluating what is best for their workflow, and then sometimes having a consultant with clinical expertise evaluating their workflow processes, the way they answer the questions, and then also helping validate their data.
Right. And, I think that's the worst part of CQMs. The coding is based on discharge. Like you said, it needs to be real time, so you're doing the right thing for the patients that are not just involved in CQM, but just doing the right thing at the time of service. So we're going to talk a little bit about, thank you, Cindy. We're going to talk a little bit about some of the measures that we've seen some issues with. I'm going to start with Core 6, which is the portal measure. So everyone that attested last year, unless they did the Flex rule, the 2014 rule, and chose the 2013 rules, had to attest to the portal. So I saw a lot of people that misunderstood what CMS really wanted to track for 6.1, and even CMS gave us 3 different directions. So they've gotten better. They're given a lot more information of what they mean by providing access. It means you've given the patient everything they need to be able to create an account. That's the 6.1 measure. The 6.2 measure is where sites are really struggling. Once that patient leaves your brick wall, you have no control over whether they're going to log on or not. Now, I always like to say I have 5 patient portals. I've only logged on to 1. So there's 4 providers that are suffering because I'm not interested in logging onto their portal. Mike's going to give us some good ideas about 6.2 in just a second. But remember that CMS has stated that patients can access the portal before they leave the hospital, and it still can count for 6.2, which is awesome. The other thing I've seen with the 6.1 and 6.2 in Stage 2 that we didn't see in Stage 1. And remember, the percentages are greater than. So for 6.1, it's greater than 50%, which CMS doesn't like decimals, so it needs to be 50.6% or higher to reach that mark. Most customers think, oh, we've reached 50%, we're good, but it has to be greater than 50%. Same thing with the 5% measure. The one that I get the most questions about now is the opt-out, and CMS actually has provided this patient electronic access tip sheet that we have the hyperlink for you. And what they were saying is, and this is what I heard from one of my friends at CMS, she goes, people are saying, hospitals are saying, we don't have time to ask that question, so we're just going to create a query, and we're going to put opt-out for all our patients, and we're going to include them in the numerator. That's not what CMS wants. What CMS has said about opt-out is the patient can choose not to access their health information, or as CMS calls it, opt-out. Patients cannot be removed from the denominator for opting out or receiving access. If a patient opts out, a provider may count them in the numerator only if they've been given all the information necessary to opt back in without having to contact the hospital. And that means they're including but not limited to their user ID, their password, where to go to, and how to create an account. And Mike, I know you deal with this daily, on a daily basis with 6.2. Can you share with us some of the things you're doing or seeing to help customers really meet that 6.2 measure?
Sure thing, Kay. On the next slide here, I just have some quick tips to help you all get your portal numbers where you'd like them to be. And I'll just note quickly that these are taken directly from my own experience, but they've also been sort of corroborated by the results of our recent patient access survey. So what we did is late last year, we asked our customers, our patient access customers, what's been successful for them? How have they sort of jumped over that 6.1, 6.2 barrier? So this is sort of a distillation of those best practices. And let's just get right to our tips here. First of all, Core 6.1 asks you to provide access to 50%. But in my view, you'd really be doing a disservice to yourselves if you don't aim for 100%. It's just the easiest way to give a boost to your 6.2 numbers. By giving access to everyone, it's just going to sort of open that field up really wide to get as many people viewing, downloading, and transmitting as possible. Second, Kay just went over this, opt-out. Rather than adopting an opt-in model, where you ask patients if they want access to the portal, you have to put the onus on them to opt out if they so choose. And as Kay mentioned, they'll be added to your denominator either way. But if they do opt out, if you note it in your registration query and give them a printed code, regardless, with directions for signing up if they change their mind, and keep those records. I think it's 6 years you have to keep those records to make sure that you've recorded that you have given them this access, even though they didn't give you their email. By doing that, you can add them to your numerator for 6.2. So that's noted in that patient electronic access tip sheet that Kay mentioned. It's a great way to change the game. And getting on to on-site sign-up, and this is the one thing I always tell my customers is, after the first 2 items above this one, signing patients up while they're still on site at your hospital will certainly be the most effective way to get those numbers up. You can have a member of your staff. You can even have a volunteer. I've found a lot of sites have great success having a volunteer sort of tasked with talking to patients about this. Or even, if CMS, if your numbers just aren't there, if you're really struggling, you can even hire a full-time employee or even a part-time employee to go to the bedside, sign patients into the portal, give them a tour, and just get them right there while they're still on site. You can also have a kiosk in your waiting areas, have someone there to help them sign up. But getting past that, greater than 5% adoption, it's tough because it's seemingly beyond your control, and it really is. But this is one way to get things sort of back under your control. Great way to do that. So whether or not you do have someone there to help them sign up, and I really do strongly suggest that you do it if you can, your staff should be aware of what the portal is, what's in it for the patient, how do you use it, and they should know how their workflows might change. And they probably will change as a result of having this conversations, these conversations with patients about the portal. It really depends who you task with having this conversation. But registrations are going to be going through the query. They're going to need to know exactly what the rules are. They're going to need to provide that code either by email or by printout. Just being ready to answer questions, suggest that patients use it, why they should use it, and hopefully make a serious effort to sign them up on site if you can. But everyone who comes into contact with the patient should be considered a stakeholder in this process, in this 6.1, 6.2 process, and should be trained on the portal accordingly. And getting to marketing, absolutely use every method you can to get the word out. Posters, brochures, social media, signage, buttons, press releases, whatever it takes. There's so many ways to get the word out, and unfortunately, it's something you're going to have to do. When they go into the waiting room, they're going to have to see that the portal's available. They should see what's in it for them. Talk about the benefits of the portal, what the features are, and if you don't have a marketing department, you can always hire a consultant because this is absolutely key. Patients have to know it exists, what's in it for them. And then finally, just get creative. You can have a raffle. You can give away an iPad to those who sign up to the portal on site. You can give away a free cup of coffee, even something as simple as that. You can hold staff contests to see who signs up the most patients. What really works is getting your stakeholders together in a single room, coming up with these workflows, coming up with new ideas. Get them together regularly, see what's working, see what's not working, and really go from there. And so with that, I'll hand things back to Kay. Kay, I hope you feel better soon.
Yeah, it's this overload on meaningful use that's done it to me. Thanks, Mike. That was great information. I wanted to talk a little bit about Core 7. Now, I've helped a lot of sites that have been audited, and thank goodness all 64 passed the first go-around. But there are some hospitals out there that have had their money recouped because of the risk analysis. I had a site that I was working with to help a test, and we got down to that question. They go, oh, it's just an easy one. Yes, we did. I said, did you do it this reporting year? They go, do we have to do it every reporting year? So remember, this is an ongoing, just because you say once that the first part of stage 2 every year. And they added something. Some of these times CMS sticks in these little FAQs, and they don't really do a good job of advertising them. But right here, it tells you some changes in stage 2. You must have address your encryption and security of your data. So you need to add that to your plan, and of course, always have your remediation, ongoing remediation. What are you doing? There's also a guide to privacy and security that ONC did. I'm happy to send it to you. It's about a 29-page document. Really good job that they did on that for what to do with your risk analysis. MedRec, I could talk about this for a long time, but basically what I wanted to say, and Cindy, I want you to chime in because you're a nurse and I'm not, But basically what I was seeing from customers is, first of all, this is not a unique measure. So I had customers saying, oh, we only want to count these patients one time. There are several of the measures that are not unique based. So that means that doesn't apply to this measure. So what you need to really remember is CMS wants you to track if you receive a patient from another care setting and you believe the encounter is relevant to do meaningful use, MedRec. I have most of my customers are doing it across the board regardless. They're not looking at where the patient came from. They're doing it across the board. So be sure that when you set up your MedRec that you're following through with that and looking at the whole workflow. I've seen some sites that do pre-admitting. They talk about the MedRec and pre-admitting the patients admitted. They don't update. They don't put the last time the patient had a med, and it's failing med reconciliation. So Cindy, what are you seeing? I know you talked to me recently about some of the stuff you're seeing.
Right, and I feel like what we're really focusing on this webcast is just speaking to a lot of workflow, and that's just generally what meaningful use comes down to is the processes that you have in place to make it work specific to your facility. And there are lots of issues that I'm hearing about. MedRec as in general is just a huge task to roll out, even compared to CPOE. So it's important to just make sure that number one, if med reconciliation takes place at the beginning when the patient comes in, and then if the physician makes any changes, if he makes a patient NPO or changes any orders, that that reconciliation takes place again once those medications are ordered a second time, or let's discharge this or DC this and do this instead. So it really is a continual process throughout that patient admission, and so it's really, really important to just offer the education to your staff and physicians and pharmacists, whoever it is that primarily does the medication reconciliation, just educating and making sure that the best workflow is in place to make sure that you can meet that threshold for your transitions of care regarding the medication reconciliation. So, Kay, with that, we can turn it back to you.
Okay. Thank you, Cindy. I'm on to my most favorite measure now, Core 12. No, I'm just teasing. What CMS did with this, and I've told them many times, they don't understand hospital workflow. If you look at some of the key players in meaningful use, none of them have worked with hospitals. The infrastructure wasn't there. They pushed this measure out. And the thing about it is, those providers that you're providing that transition of care document, they don't want it. I hear over and over that they don't want all that information. I have asked CMS if that transition of care could be reduced to the last 24 hours. That would make it more beneficial, but so far I've only talked to a few sites that they're transferring providers or even consuming that CCD. Thank goodness that CMS says you don't have to prove that they opened it, just that they received it. So Core 12, just keep in mind that it is a disaster. I was hoping that there'd be some relief, and maybe one of those modifications will be this. But 12.1 is whether you provide paper or electronic, they can be added together. Core 12.2 is electronic, and what CMS wants you to track is that that CCD was received on the other end. Excuse me. So when you get that report back from your HIF, that's what they want to see, that that CCD was received. They've got a lot of FAQs. Excuse me. One of the things that they just published was that, first of all, the HISP report was coming back, but vendors were leery to accept it because it wasn't certified. So last fall, CMS did say that you can consume that report even if it isn't certified. So Cindy, to help my voice, would you just jump in and say some of the things that you've been seeing?
Absolutely. So, like you're saying, this measure can be a disaster for so many sites, and so that's why it's really important to make sure that you have a good HISP that you've contracted with. Some hospitals are working with their HIE to connect, and we're seeing success with hospitals that have worked with a specific HISP. Particularly, I'm working with a hospital that has contracted with MedAllies, and not to give a push to any particular vendor, but I just want to share some success that they've had in just the ease of the process. And what this is MedAllies issues a assigned email address that's a direct email that's encrypted, and so the hospital is able to automatically send an email to that provider once the patient is discharged or goes through, is transitioned to another care facility. And so, this facility is actually meeting transition of care with ease. And so that's really the importance that we want to emphasize, is making sure that as you're going through this process that you select the right HISP that, again, really works for your hospital and makes it easy for you to be able to meet the transition of care measure.
Yeah, and Cindy, that's great. You just reminded me of something. One of my customers, the HISP told them they will not be providing them a report of what was received. So that vendor's not giving that hospital what they need to be able to track this measure.
Right.
Thank you, Cindy. And I always say the yes-no measures sometimes get overlooked, and this is a good example. For Stage 2, Core 13, 14, 15, the public health interfaces, CMS has published this tip sheet, and if you don't do anything else from this event, please look at this one. Because what has happened is CMS has, given you some strict umbrella of what ongoing submission means. And this document has the criteria, and if you don't match this criteria, you don't meet this measure. So please read this. Make sure that you're meeting all three of those public health interfaces for Stage 2. And Core 16, Emaar, there's a lot of misunderstanding, I think, of what CMS really wants you to track on this. And Cindy, you can share some, but what I have found doing all my research is what CMS believes that including each individual dose connected with a patient, that it's going to be safer for the patient from the Emaar perspective. And all those doses of medication in the order, which all doses are tracked using Emaar and doing the assisted technology, they are going to amend the measure that states that to be able to meet this measure, if a medication is ordered and not all doses are included in the Emaar, then you did not meet that measure. So I'll include that statement from CMS with our PowerPoint that we're going to send out to you. But there is an exclusion. When Stage 2 came out, the spec sheets, I started pointing out things that didn't make sense to me to CMS. And there's one I pointed out on CTOE, and a year ago they just changed it. But this exclusion does apply, and what it is, especially I see a lot of critical access hospitals, if your inpatient census for your reporting period is less than 10 patients, your average census, then this exclusion applies to you, and you can actually meet this measure without having to do Emaar. So Cindy, thanks again for trying to help me. Can you kind of tell me some of the issues you've seen with Emaar, especially from being a nurse?
Exactly, and what you're saying is the new addition that there's adding that if you don't include every entry for that medication, then it's not going to meet the measure. That's where the challenge comes in, and this Emaar seems like it would implement your BMV. It seems like it would be a smooth sailing to meet this measure, but it really isn't, and it comes down to, is the product that you're using user-friendly? A lot of hospitals are facing issues with just the simple barcode placement on the medication label. If that's not positioned right, then sometimes it won't scan with whatever tool you're using, your barcode scanner. So, in emergent situations, it is often required that the nurse just, omit the barcode scanning and just later enter it manually on the Emaar. And this is where those medications for that patient are dropping out. So again, it comes down to making sure that your process that you have in place is user-friendly and it doesn't delay anything for the nurse in giving the medication. And what we really are trying to emphasize with this webcast as well is doing what's right for the patient. So, we have meaningful use. We have to meet all of these measures according to CMS, but it all comes down to patient safety. And, that's really what Emaar is all about, is making sure that you're using the 5 rights for medications to ensure your patient safety. And a lot of that just comes down to, is it user-friendly for the nurse?
Okay, thanks, Cindy, so much. I'm going to move on to a thing that I hear a lot from customers and just people that I talk to in general, is tracking all this information, keeping all this information. I have one friend that had 4 different binders of all their proof for meaningful use. And one of their employees left and took one of their binders. So remember, you can be audited for up to 6 years post-attestation. You've got to have this documentation. Are you tracking the measures correctly? Have you put any changes that CMS has provided? Some of these documents that we've given you in this webcast, put that with your meaningful use information. What I am seeing is a lot of times when that site is audited, the person that did the attestation is no longer at the hospital. So one of the things I recommend is, I call it Data Dashboard Friday. Every Friday, check where you are on meaningful use, but also check on the web page. You can actually see if you've been selected for an audit. That email goes out to whoever signed the attestation. Since it's 6 years, you want to make sure, because you only have 3 weeks to answer. So just Friday, see where you are on meaningful use, and then also see if you've been selected for an audit. It just comes down to being very careful on what you're doing and watching. So remember, too, that CMS, like I mentioned, has some errors. A couple of the errors that I found on spec sheets is Core 6 and Core 12. Guess what? The method does apply, but they left it out of the spec sheets. Remember, the observation service method means all your observation patients, whether they're ED observation or whether they're on the floor observation, all observation patients need to be included. And you know what, Cindy, I've had a lot of customers tell me that they're going to take the meaningful use ride. They're not going to worry about it. They're going to get their numbers. They're not going to look at anything again until it's time to attest again. And Cindy, what are you seeing with sites that come to you for help on tracking meaningful use or keeping their documentation?
That's really proving to be a real barrier. Is, like you said, sites have implemented everything that's needed for whatever stage of meaningful use they're in, and like I said before, it's kind of meaningful use is taking a back burner, and now we're focusing on ICD-10. But the issue is that you can't just let it slide. You can't sort of take the meaningful use vacation and go to the beach like we'd all like to. And this is where it's really important to stay on track with monitoring. And so what we have found in working with our customers is that it's really beneficial to have a dedicated resource, to have a staff person that's available that can, evaluate the tracking tool, whether that be MUM or another vendor's tracking tool, or whatever method they use, whether it be running off reports. But it's essential to stay on track and to really evaluate where you stand on a weekly basis. And so the big question comes down to is, do you have a dedicated staff person available that can be pulled away to do this a few hours a week? And it's not just looking at your thresholds, but evaluating your data, making sure that the numbers that the patients that are not passing the measure, are those correct? And digging into the medical record and evaluating why the patient failed. So. And then another aspect is making sure that all of your proof of evidence is in place, and not waiting until the end of the reporting period to get all those documents in place and uploaded to MUM. So, you really don't want to wait till the last minute to compile the documents because it can be a daunting task. And, at the same time, you want to make sure that you have everything in place so that for not if, but when you get an audit notice, then, there's not a stress. You have it all right there. And, like you were talking about before, Kay, the security risk analysis, it's super important to make sure that you're keeping up with remediating all of those gaps that were found in your risk analysis. And, every hospital has them. And so that's going to be the big focus for audits this year is, looking at the security risk analysis and making sure that you're staying on top of your documentation and making those process improvements. As we've seen with the audits last year, that was the reason for many of the failures and many of the situations where hospitals had to give their incentive money back because, they weren't keeping track of their documentation for the security risk analysis. So, it really comes down to what do you have internally? What can you do to make sure that you're monitoring this on a regular basis? And do you have the internal resources to carry this out? So, as we've had success with our customers, you might want to consider having an outside consultant or, iAtric Systems consultants. We're offering a continuous monitoring consulting where, we kind of do the work for you, where you don't have to have that dedicated resource person. So, and it's a second set of eyes looking at your information and making sure that everything there is all in place and that, each of the components for every meaningful use measure and CQM, that all of that information is there and you're documenting correctly. And then, sometimes it does come about that there are some gaps in your processes, and so that's where we're also able to offer some process improvement suggestions. So, it kind of just helps to take the stress off of the facility, to take the stress off of hospitals, to let a consultant be the one to watch the percentages and make sure that you're not, teetering on those thresholds, because it really comes down to, ensuring that your meaningful use is successful and, again, helping to improve your patient safety and quality of care.
I wanted to ask you, you hear a lot about mock audits. What have you heard from customers that you performed mock audits on? Were they surprised at some of the holes that they had?
Absolutely. The mock audit is, it's just as important as having like a joint commission mock audit, or having someone come in and have a survey on a particular process. Because absolutely, with meaningful use, there are so many aspects that you can't be expected to know everything. And even if you have huge teams working towards your meaningful use implementation and, keeping that going, there's always something that could potentially be missed. And so having a mock audit is really important, and it's something that I'm really emphasizing for this year because CMS has said that, starting this summer or this fall, whenever those audit notices go back out for this year, there's going to be a lot more hospitals audited this year than there were in the past. And, also, if a hospital was audited before, then they can pretty much know that they're going to be audited again. So having a second set of eyes coming in and looking at all your documentation, making sure that it's in place, it's really just sort of an insurance policy that, just helps sort of take the load and the stress off so that you don't have to have that really sick feeling in your stomach whenever you get that audit notification.
Yeah. I've had several customers call me when they got those notices and they had a sick feeling. So thank you very much, Cindy. I just wanted to finish up with what I've seen on stage 3. And I'm just going to, because we're running out of time, I just want to quickly give you a couple of the things that I've seen. You know, Stage 1 clinical decision support was 1 rule. Stage 2, it was 5. Stage 3, the proposed is 15 different clinical decision support rules. CPOE, which now lab and radiology is greater than 30%, they're all going to go to greater than 60%. The CPOE is going to need to have a referral that's automated. I can't wait to see more details on that one. Advanced directive is going to stay, so you get one easy one going forward in Stage 3. They're retiring demographics. They're retiring vital signs because vital signs can be tied to a CQM, and they're retiring smoking. Core 8 for Stage 2 is the clinical lab results. It's going to go from 55% to greater than 80%. Emaar is going to go from greater than 10% to greater than 30%. And they're adding mismatch. And keep in mind, these are the proposed. I get conflicting dates from when the final is going to actually be provided. Once it's provided, iAtric Systems has a team already in place that we're going to go through each one of the measures. And any questions we have, like we learned from Stage 2 with all those errors in the spec sheets, we're going to address them with CMS right then, so that when we start our first level of code, it's going to be based on what CMS really intends, not the mismatch of what they give us in those specification sheets. Just a couple of other ones to let you know of is that for your portal, the automated transmit, the blue button, is going to be required. So your patient, I haven't talked to anybody yet that their patients have done sent their own CCDs, but it's going to be required to have that blue button technology. Also, patients are going to be able to amend their medical records online. Patient education for the top 5 non-English language spoken nationally, you're going to have greater than 80% of your patient education in multiple languages. And the last one that I think is really interesting is 10% of your patients with health care events, and they define that as going to the ED, admitted to the hospital, discharged from the hospital, or death. You have to notify their PCP within 2 hours of each event. So I'm anxious to see how that's going to play out with the final for Stage 3. So I'm going to go ahead and change it to the last slide where it's the questions and answers, and I believe that our moderator has got some questions for us. So, Sandy?
Yes, Kay. I'll try to get through these questions, and we are getting close to the top of the hour. If we don't get to your question, we will send out a Q&A document to everyone, to all the attendees with the presentation. So let's get started. With the Flex ID rule, if passed, would that be for all or for only those that attested to Stage 1 in 2014?
If that rule this is Kay, I'll answer that. If that rule passes, it's going to be everybody regardless of your stage or your year for 2016. So it would impact anybody regardless. I think they're trying to point out that people that are just going to Stage 2, that's a really big jump, but not just people that have just gone to Stage 2. I've had sites that have tested to Stage 2 last reporting year, and they're still struggling with some of the measures. So it will be everybody, all hospitals.
Thank you, Kay. Did Kay say 50% of CMS reimbursement tied to VBP by 2018?
That is.
Are you there, Kay?
Sorry, I was coughing. Yes, that's an article that I'll be happy to attach to send out with you. It's a huge leap for us to get there by 2018, so that's why I really caution you, your CQMs are going to be more important than ever.
Great. What about portal opt-outs for patients not allowed emails, prison population?
That's a good question. Mike, do you want to address that? And I can say what I heard from CMS too.
Okay. As far as I'm aware, if they don't have an email, no matter the reason, if you provide them with the access, once they are allowed to have email, they can access the portal, and that will count toward your numerator. Okay, have you heard differently?
Yeah, that's exactly right. That what CMS said to me is, hey, we've got these measures pretty low, greater than 50% and greater than 5%. So we took into consideration patients that die that will never access. We took into consideration patients that are in prison, all of these other items. I've heard a lot of hospitals are now, along with their information, are giving them free email addresses and helping them sign up right there while they're in the hospital. So there's no exclusion to that measure, and we've checked twice now with CMS. Thanks, Mike.
Okay.
Thank you, Kay.
We have been told that MedRec has to be done at least once per med during the stay. We have heard that the intent is at care transition, but that has to be done once. We've never heard anything about it being done when a patient is NPO, etc. Do you have any supporting data for that?
I'm going to go to my nurse. Cindy?
Again, I guess that question kind of comes down to your workflow, and do you have a process in place for MedRec after, say, a patient is transitioned to or goes to surgery, comes back to the floor, and new orders are written? So do you have a process in place for medication reconciliation at that point, as far as the physician, continuing current medications or such? So I guess I would just reference the CMS regulation for that. There's not anything specific to that. However, again, it just comes down to the workflow process that you have in place for your facility.
Okay. How is Measure be counted? We send out the CCD and get a processed message back in Meditech.
Okay, I'll go ahead and address that one. I'm assuming for the electronic CCDs, if you have that message coming back from your HISP that CCD or transition of care was received by the transferring provider, doesn't have to be open, just received, and that's coming back into Meditech for you or any HIS system, they can now consume it, and it won't be against the certification. So I've seen a couple of hospitals I've worked with starting to consume that. It has to be, if it's not consumed in your core HIS system, a lot of ways that you're going to track it are going to go to a manual process until it's contained into your EHR system. So again, if you have any more questions, just feel free to send me an email, and I'll be happy to talk about Core 12 with you.
And our last question, because we are at the top of the hour, Core 6.2, can patients in pre-registration status be counted if they log into patient portal?
I'll let you talk about this one too, Mike, but I've talked to ask that same question. And keep in mind that if the reporting period goes to a quarter, what CMS has said is any access to the portal during that entire reporting year, if that patient is in your denominator for that actual quarter that you're going to test, that access can count. So they made that change last year saying, everybody's doing a quarter, we're going to give you that full reporting year to be able to count that patient. Mike, do you have anything else to add to that?
No, except for just the fact that you're absolutely right, as usual. They can, as long as they are seen as a patient in that same quarter that they access the portal, that does count.
Yeah, it's got to be in their denominator for their reporting period. That's the patient population. And remember, this is based on methods. So if you're doing the observation service method, it's all your EDs and all your observations. If you're doing the all ED, it's all your inpatients and it's all of your ED patients. So that really kind of almost doubles your patient population to get signed up on the portal and access.
That's right.
Well, thank you, Kay, Cindy, and Mike. We are at the top of the hour. I'd like to thank everyone for attending our webinar today. You will have the opportunity to fill out a short survey to tell us how we did. The survey will appear when you close your Internet browser. For your time, your name will be entered into a drawing to win a $100 Amazon.com gift card. All of our drawings will be held at the end of the month. Be sure to follow us on LinkedIn, Twitter, Facebook, and Google+ for up-to-date product information and announcements. If you'd like more information, please contact your IATRIC Systems account executive or send an email to info@iatric.com. Again, I'd like to thank our presenters, and also once again like to thank everyone who took the time to join us today, and we hope you have a great day.